Very interesting talk today. A lot of people are very interested in mental health issues. And I got to tell you, one of the benefits of our Penn Heart program is the extension beyond the heart program of the network of professionals such as we have today, who are not only specialists in their field, but because of the partnership with the transplant program, they know us as transplant patients. And let's face it, there are some of the things we face that are unique from those general population out there. And it's really special when you go to a doctor who understands the transplant side of you as a patient. And so that's one of the things I think that distinguishes my favorite program here, meaning Penn, and other programs. And so over the years, I've had occasion to use that network in many ways, and it's really special to have a doctor who says, I understand. And the transplant program refers you to those people that they refer to all the time, so they work together. You have a doctor who wants to change your medications, he knows he can't do that. He's going to contact the heart program to make sure that that fits their protocol. And so just pointing out that benefit to you. Congratulations. You're alive today and you're here to share this. Isn't that amazing? Welcome. And the question is, how many years are you out? So starting right down here, how many years?
21 years.
How many?
7 months.
Say it real loud.
21 years, 7 months.
Wow. 24 years.
17 years, 8 months, 1 week, and a couple of days.
And a couple hours. Next? 8 months. This is a very special time to come out and see the challenge you have in front of you. You thought you were just fighting to get to the end of the first year. Talk to some others. Coming across, Tom?
19 months.
19 months, looking great. All right, almost 10 years. We'll take it.
8 years.
I'm sorry,
Yeah.
almost 10. What'd you do, get them both together at the same time?
Pretty close.
Give discounts for those twins, right? Go ahead. Next. I love it. And a kidney. You got a bonus. 8 years. Nice and loud. How about? 8.5. Okay.
11 years, 4 months.
Next. 12 years. 4.5. Okay. Coming across? 2 years, 2 months. Way to go. Bob?
A bit over 5 years.
All right. Luther? Almost 8. 9 years, 6 months. Coming across. Lou? 7 3/4. Okay. Next row up. Who we got up there?
3 years.
3 years. Okay. Beyond that? The problem is I can't tell who's a patient and who's not because you all look so good. So just shout it out. How about over here? Any? 10th year? Is that what you said? 10th? Very good. And those about to sit down up top? How many years?
5.5.
5.5. And down front? Almost 5. Oh, we're going to do that in just a second. Hey, anybody add that up, isn't that amazing that that many years of life have been added through the program? How many years are you out? How many years are you out from your transplant? 2. All right. And just know that somebody else coming in late, they probably got some of the number to inspire us. And it is really awesome to me to stand here and look out and hear the 8s, the 10s. I mean, the numbers keep growing as that survival rate keeps going. So what a great tribute to a program and to our social workers who act as the steering wheel for some of that care. And so we thank you, social workers, for doing that, for this great program that's making us challenged each day with what are we going to do with our life today. And the mind guiding that is key, and that's why the topic today is so important. And so a number of people have said, so Jim, how long are you out? 25 years. We had a party recently. And the other question people ask is, so Jim, how old are you? Well, you know, there's different answers to that. You can count the years, and this Sunday I'll be 76. I don't believe that. My wife said to me, what are you doing? I said, I'm recalculating that to see if it's right. I couldn't believe it, right? And for those of you who faced the transplant, I don't think you ever expected to see the kind of numbers you're seeing in terms of life, did you? And look at it now, especially when you're looking back over it. And so the real question is, what have you done with it, right? A challenge we all face every day. And so TRIO, Transplant Recipients International Local Chapter here, we had an event in January, and somebody brought a cake, and even though my 25th anniversary is October 19th, never forget that. And every time I say that, I think of Roberto. Roberto was over in Brooklyn. He was celebrating his 38th birthday, was on the street and beaten about the head with a baseball bat. He ended up in a coma. Now, we know coma is not death, but 8 days later, his brain stopped. His brother, Gilberto, led the brothers and sisters to making the decision to donate his organs. We didn't have registries in those days, 25 years ago. Quarter of a century ago, isn't that amazing? And so his heart ended up over here in Philadelphia. And every year when I send that thank you note to the family, I reflect on the idea that he's dead, but his heart is still beating. And because of that, and in thanks to him, I'm here to share this celebration with you. And so I hope you reach 25 also. Now, having said that, we're missing two people among others here tonight. One, Bill Soloway, you may know. He's usually here working with the camera work with Brad and so forth. He's all over the place. I mean, if you know Bill, he's just using that heart to its fullest. He sends his greetings from Florida. He's down there with his dad, who he's been taking care of. He's in his elderly years, and his dad had a stroke a couple weeks ago. So he's working to find a place where his dad can get the care he needs. But every year, they've gone down to spring training in Florida. And so he got some medical caregiver to come with him. And he took his father down there. That's where he is right now. And he said, you know, it's probably going to be his last time down there. And so, but Bill, he's living life to the fullest, and that's what we would offer each one of you, to find out how to do that in your own life, right? The other person that's missing, and many of us know him, is John Clyde. John Clyde was always the last one. I mean, he was about a year out from me. And so when we share that, he went through 2 heart transplants, and he was out, I think, about 26 years. John passed away recently. We're all going to pass away, so let's not even worry about that. It's coming someday. Today you're here, celebrate it. I knew John, but I didn't know John. I went to his funeral. I've never seen a funeral like this. It was absolutely amazing. And he had so many friends, and he had done so much with his life. He was mayor of his town. He was on their board. Everybody there, I mean, I would say there was 200 to 300 people that came out in a rural area of North Jersey here to celebrate John's life. And so while he's not here today, I'm sorry, I'm going to tear up just thinking about it. He's here today, looking down on us and celebrating you. And so don't deny the day. Don't waste it, whatever that is. And so with that, I'm going to pass it over to the speakers today, Bob Wandrup, and we have some patients here who have had services from these people, and Arpita. And so Arpita, you're going to lead off. And with that, I'm going to...
Good morning, everyone. I'm Dr. Goswami, Arpita Goswami. I'm one of the transplant psychiatrists. Today, me and my colleague, Dr. Weinreib, we are going to talk about anxiety, depression in transplant patients. Our talk is divided into 2 parts. The first part, I'll be talking more about how do we recognize anxiety, how do we recognize depression, Uh, what are the triggers in transplant patients, both pre and post? Um, what are some of the remedies we can take on our own? What are the remedies which we can do without medications to overcome this two condition? And my last part would be more on caregivers burnout, which I feel is a very, very important topic, especially in transplant patients. And I'm going to talk a little bit about that. We both have no disclosures. So, what is anxiety? We all worry about situations in our life, especially in transplant population, a lot of things going on, your illness, medications, coming to hospitals in and out. Those are very common that it will cause a lot of worry. But when we can define it as anxiety, which is something you need help with, so it's a body's way of responding to being in danger. It enables us to run away or flight. So it actually activates the fight or flight response in our body. So it can happen when the danger is real, or sometimes even when the danger is perceived, that's in our head rather than in reality. So what happens in anxiety is we have an alarm system inbuilt in our body. That alarm systems get activated, and it's actually a survival mechanism. It's a life-saving response that when we see something actually in danger, we feel anxious, and we have the flight or fright response activated. However, in anxiety, what happens is our body goes into a scanning mode. We are constantly on lookout for danger. We become hyper alert to any signals. And that makes it likely that the alarm system of our body can sometimes even be activated falsely. And that's why we start feeling anxious and we worry about things. I'm going to talk about more symptoms later. And then the next slide is sadness or demoralization. I put this slide before depression because I wanted to distinguish between, which is a normal reaction versus an abnormal reaction. So being sad or demoralized is actually a normal reaction. We all feel sad, we have all experienced it, and we'll all experience it. So it's usually a normal reaction to stress, and it's triggered by any difficult, hurtful, challenging life circumstances. But it's recognized by mainly two states of mind. We are in a state of distress, and we have some uncertainty about which direction to take. But it's different from depression. So what happens in sadness is a sad person can actually experience hope and feel enjoyment when the adverse conditions are overcome. So when we get over the adverse condition, we start feeling good again. That does not happen in depression. The treatment for sadness is mostly understanding the person's plight and distress, encouraging that person, and also getting that person increasingly engaged in activities that make him feel better. Sometimes both sadness and depression can actually overlap. So what is the abnormal part of the sadness? It's the depression. So what is depression? So a lot of my patients, when I see them, when I ask them, have you been depressed? They tell me, I don't understand what depression means. Yes, I am sad, but what do you mean by depression? So this is what we mean. You feel sad, you have low mood. You lose interest or pleasure in all activities that you once enjoyed. You have change in appetite. Either you gain weight or you lose weight, which is unrelated to dieting. You have trouble sleeping or you're sleeping too much. There is loss of energy, increased fatigue. There is a feeling of guilt, which does not have any relevance why you are feeling guilty. There's a feeling of worthlessness. There is difficulty in thinking, concentration, or making decisions. Then occasionally you have thoughts of death, suicide, giving up. What is important is these symptoms must last at least 2 weeks for a diagnosis of depression. So if these symptoms do not remit even if things change for the better. So it's there. That is one of the most distinguishing point between we are sad versus we are depressed. The duration of time and the non-remission of symptoms even though conditions may change. So just in a nutshell, sadness is a normal emotional reaction. which all of us face. Depression is not a normal reaction, it's a disease. When we have identified the symptoms I just mentioned, for more than 2 weeks, month, it's important we see you and we evaluate how significant the depression is and we treat it. That is, it is a disease, so it needs to be treated like any other condition. So sadness does not impact our ability to function. We can function normally, but when we are depressed, it does impact our ability to function normally. In sadness, our thoughts are realistic. But when we are depressed, our thoughts are unrealistic and negative. And I'm going to talk more about this in my later slides. There is a sense of hopelessness in depression, which we do not see in sadness. Sadness generally lasts for a short period and it goes away, but depression lasts for weeks or months at a time. And most of the time, it needs treatment. So this is just a little cartoon I have put to distinguish between this person feels sad because he did not do well in the exam. Whereas the other guy, you can see the symptoms, what his mother says, my son seems to have lost interest in his studies. It's a month since he has gone to college. He does not speak to us at all. I'm really worried. And the student is thinking, my parents are always quarreling, this bothers me so much. I don't feel like studying or doing anything, so loss of interest in things. I don't have a future, I hate my life. So the thoughts are very negative and unrealistic. So why are we talking about anxiety depression today? That's because it's pretty significant in our transplant population. And 50% of recipients suffer from anxiety or depression prior to a heart transplant. And post-transplant, a quarter of patients actually develop depressive disorder and 17% develop anxiety disorder in the first 3 years of transplant. So the numbers are pretty significant, and that's why it's important that we recognize it, we treat it. How do we recognize anxiety? I was just telling of some symptoms before, like I was giving you some definition, but really on day-to-day basis, how do you recognize? When our worry is excessive, more than anyone, it's persistent, it does not go away, you keep worrying all the time. It's unreasonable, you worry about things that you should not be worrying about. You have a sense of edginess, restlessness inside you. You are irritable. The concentration is poor. You have difficulty in sleeping because you worry so much, your thoughts are always, mind is always racing. A lot of my patients say, I just can't seem to shut off my brain. It keeps on running and I keep on thinking. There is some muscle tension, you feel always you are tensed. And there is also some fatigue. And also common symptoms are the sense of choking, sense of dread, rapid heartbeat, legs start a little wobbly, you feel shaky, you sometimes feel faint. Anxiety, if it's too much, can result in panic attacks. That is something, again, some symptoms are sometimes similar, symptoms are sometimes very acute. So when someone has a panic attack, how do you recognize it? You start feeling chills or hot flashes. You start sweating. Sometimes you feel nauseated, you feel like you have knots in your stomach. You become a little shaky, your limbs can sometimes be tingling, there can be numbness, you sometimes feel dizzy, and most important, sometimes that is why it masks our heart symptoms or vice versa. You have palpitation, you start breathing fast, and you feel you are having a heart attack. A lot of our patients who have panic attack, they think they're having a heart attack and they end up going to the ER and then they are ruled out from having any heart condition. When that happens again and again, you know you're actually having panic attacks, which are very similar to having a heart attack at times. But one of the most important things to remember about panic attack is it starts suddenly. The symptoms peak by 10 minutes and then usually they subside in 20 to 30 minutes. So it does not cause death. It peaks, it goes up, and then it comes down. So if we think we are dying because we are having those symptoms, all we have to do is remember this is not going to last for long. It's anyways going to go away after half an hour or 20 minutes. It rarely lasts for an hour. So what are the different types of anxiety? We have generalized anxiety disorder. When you're constantly worrying, it's what ifs. What if this happens? You're worrying about things that have no relevance. The worrying comes in your way of day-to-day functioning. You are not able to function because you worry so much. That's generalized anxiety. Again, that should be for more than 2 weeks or more, not 1 day, 2 day. If we say it's more than 2 weeks or more, up to a month, then and the constant worrying that comes in your way of getting day-to-day activities done, it's generalized anxiety. Another type of anxiety is obsessive compulsive disorder. This is the OCD, where people have intrusive thoughts. Thoughts will come in your mind, and then you have to do something again and again to get relief from those thoughts. So the obsession are the thoughts that come to our mind and bother us all the time. And the compulsions are the activities that we do. It can be very simple activities like washing your hands multiple times in a day, checking the lock, checking the gas, but not 5 or 6 times, but maybe 30 times, 40 times. That again actually comes and limits your functional capacity, that you're so obsessed, you're doing those things again and again that you feel it comes in your way of functioning every day. A lot of people, when I ask about the anxiety, the obsessive compulsive, they said, oh, I have OCD. So that's like a very loosely used term, I feel, because a lot of people have OCD personality disorder, which is like, you are very organized, you want to get things done properly, you make sure everything is in the right place, your medications are, so that is not really a disease. OCD becomes a disease when the thoughts and your repetitive actions goes to that extent that you are not able to function because of those actions or thoughts. It comes in your way of functioning. You can't sleep because you wake up like 30 times at night to check the lock or check the gas. So it actually impairs your function, day-to-day functioning. So that is when you need to see us and get treated for OCD. Panic disorder is when someone has repeated panic attacks, and then they understand that they're getting a panic attack. A lot of people get a sense, oh, I know I'm going to have a panic attack. Repeated panic attack, getting a sense of understanding that they're going to have a panic attack, they know it's coming. That is when you call a panic disorder. Then there is phobia. It's also a type of anxiety. You have fear for a particular situation. Most of our patients, sometimes they have phobia for needles, for blood, for the oxygen mask, for any smell or sight in the ICU. Those are specific phobia that actually comes in their way of getting engaged in care because they don't want to go to the hospital. They don't want to get tested because they are so scared of those particular things. Then there is social anxiety, anxiety of social situations, that is fear of going out, being criticized by others. People feel, oh, people are looking at me, they're talking about me, so I would rather not go out. And last but not the least, but very important, is the post-traumatic stress disorder. It's a whole big talk on its own, but I want to just emphasize for all our transplant patients, because it's a very, very important thing we often as psychiatrists face in our post-transplant patient population about the post-traumatic stress. So this is a condition that happens when people live through any traumatic experience. And in our case, it could be medical events, your heart conditions, surgery, post-surgery, ICU stay. There can be various factors. So for our patient population here, in the transplant population, the post-traumatic symptoms are mostly related to our health condition, the recovery, hospital stay, or our experience in the hospital. So what happens when how do we recognize that someone is having PTSD symptoms? People start feeling numb. They have upsetting memories about what happened in the hospital. They get nightmares. They have flashbacks, that is, those events come and play in their mind again and again. Some sound, some events, some sights, it come in their mind. Then they avoid places or people that remind them of those particular trauma that they had gone through. They have intense feeling of fear or anger. Sometimes they get frightened or startled very easily. So these are some of the common symptoms. They have sleeping difficulty because of the nightmares. They'll wake up in cold sweats because they have those nightmares of those events that they have experienced. These symptoms are mostly after a patient comes home. It can happen, mostly if it happens within a month, like within 30 days of the event. Say you were admitted, you had a surgery, heart transplant, you had a very complex recovery course, you were in the ICU hospital, and you come home. It's natural you might have some kind of distress when you think of your hospital course. Within a month, it's called acute stress reaction. So it is kind of a common thing, again, like sadness. It goes away. If it persists beyond a month, for many months, then we give it a diagnosis of post-traumatic stress disorder. Now, it can come and go. So anytime when people are under stress or they're exposed to the same situation, like get readmitted in the same unit, same floor, they can experience again the post-traumatic stress symptoms. Sometimes it can happen years after the trauma. So this is something very important. If you feel you're having these symptoms, even a year down the line, something reminds you of the hospital, you get distressed, you're avoiding, you're having some flashbacks, you get startled easily, you are having nightmares, it's important that you see us and let us know so that we can treat it, because it's a treatable symptom. How do we recognize depression? As I said, people have low mood. They have change in appetite. They have sleep disturbance. Sometimes depression can come as mood swings, irritability, agitation. They have extreme fatigue, and they have difficulty in concentration, and sometimes feelings of hopelessness, giving up on life. Now, when we are anxious or depressed, we have certain kinds of thoughts all of us have in our mind. Now, I try to compare both. So in anxiety, it's more, as I said, it's the body's alarm system getting activated, so it's more about fight or flight. It's about perceived or real danger. So when in anxiety, when people who suffer from anxiety, the common thoughts that goes through their mind are, I'm in danger right now. The worst possible scenario is going to happen. I won't be able to cope with it. So these are the very simple common thoughts that comes to someone who is suffering from anxiety. Depression, it's more negative and unrealistic. Everything is hopeless. Nothing can change. I'm useless and worthless. It's all my fault. The world is a terrible place. Everything is going wrong. So you have a very negative sense of your own self and the world around you. And you suffer from those kind of thoughts. So these thoughts then actually generate certain kind of behavior in us. So with anxiety, with all those thoughts about I'm in danger, nothing is going to right, things are not coming in place. So what are the behaviors you have from that? You avoid people or places. You are going to certain places only at certain times. For example, you're shopping at smaller shops, you're going at less busy times, so you're not going there when it's crowded. You try to escape and leave early when you are in a crowd or when you're amongst people. And then sometimes you engage in safety behaviors, like you avoid eye contact, you fidget with your hands, you do something, you have a glass in your hand and you try to just keep your mind distracted because you're feeling so anxious that you have to do something. In depression, the behaviors that people exhibit are they tend to do less and less. They stop doing things that they used to do and enjoy. They withdraw and they isolate from family and friends. They mostly try to stay at home. Now, these behaviors of anxiety and depression sometimes overlap. Anxiety and depressive symptoms, most often, they overlap. Someone who's very anxious, because of the anxiety that is coming in their way of everyday functioning, they start getting depressed. People with depression also, because they are so depressed, sometimes start feeling anxious. Why am I like this? Why am I becoming like this? I was never like this. So sometimes it comes hand in hand, and we treat it both at the same time. So just in a nutshell, when we have an anxiety, there is a cycle that goes around in our mind. So there is a trigger, which is real or imagined danger. Then those thoughts come in. I can't cope. Something terrible is going to happen. I feel bad, so there must be something bad happening. And then that gives rise to some feelings. You feel anxious, you feel fearful. Then you have all the physical sensations of anxiety, like palpitation, breathing hard, numbness, tingling, nausea, sweating. And then you behave. What is the behavior? You try to avoid, you escape, or you freeze. You try to cope by doing things that help you feel better and safe. Similarly, the cycle of depression. It's mostly anything happening in your life which causes some negative, gloomy thoughts. You become self-critical. You say, I messed up again. There's no point. No one likes me. So very lot of unrealistic negative thoughts. That then results in certain kind of feelings. You're tired. You're not motivated. You're not interested. You kind of slow down. And the behaviors that those feelings then generate is you withdraw and isolate. You stay at home, you cut off from others, you don't go out much, you don't do much. So it's like a vicious cycle. So when we treat depression and anxiety, our goal is to actually break this cycle. Medication and therapy, which Dr. Weinreib is going to talk about in his talk. So why do heart transplant patients have anxiety and depression? So there are some studies which have found out the reason why it's so prevalent in heart transplant patients. Number one is there is a lot of enduring physical symptoms and functional impairments. You all have gone through it before your transplant. There were a lot of things you could not do. You had a lot of symptoms. You didn't feel well. You had chest pain. You had palpitation. You were on some drip. So it went on and on. Then you have repeated experience with shortness of breath and life-threatening exacerbation of disease that makes you come in and out of the hospital. Then there is a stress of chronic suffering. Most of the heart transplant patients, they suffer before they actually get the organ transplant. There is also, it has been seen that there is a relationship between shortness of breath, chest pain, discomfort, and having a panic anxiety feeling. So if you remember, when you get into a panic attack, you have all these symptoms. You have shortness of breath, you have chest pain, you have that discomfort, breathing fast. So those symptoms are very similar to some symptoms that a patient with heart disease experience. So they are kind of overlapping symptoms. So a lot of the time when you're not actually having a heart symptom, you're having these and you develop panic anxiety. Then there is concerns regarding the condition of being a post-transplant patient. You already have that concern prior to the transplant. And then there is adaptation post-transplant, then there is adaptation in lifestyle, including infectious care, properly balanced diet, weight maintenance, strict and continued use of the immunosuppressive drugs, then also following the team's advices for maintenance of well-being. And there are a lot of advices you have to follow: multiple hospital visits, meeting multiple members of the team, getting tests done. So those are a lot of changes in your life after transplant. These are all the triggers, stresses in a person's life, both pre and post, that can actually precipitate both anxiety and depression, either one or both together. Now for anxiety, what are some of the causes of anxiety in heart patients? Pre-transplant, there are certain factors. Uncertainty of whether a donor will be found in time, that causes a lot of anxiety. When am I going to get the donor? Once you are listed, this starts happening. When, if ever, the call will come that a donor organ has become available. Waiting for that phone call, it's very, very anxiety provoking. When is that phone call going to come? Because you know you have a short window of time, leave everything and come to hospital. As soon as the phone comes. I had some patients who would say whenever the phone ring, I would experience panic attack because I would get so worried that is it from the hospital? Are they calling me to come for the organ? While waiting, people often experience declining physical health until you get the organ. So that can cause a lot of anxiety. And then greater dependence on medical care. You get more and more dependent on medical care as days goes by. Post-transplant, there are some factors that cause anxiety. Concern about organ rejection. The medications, which I'll talk a little bit about, immunosuppressant and anti-rejection medication that have some impact on our mood and anxiety. Feeling overwhelmed by learning about new medication, the testings and the appointments, multiple appointments that you have come to the hospital for. People may suffer complications post-transplant and require prolonged hospitalization. And then some people have slow recovery period. Those are all reasons that people get anxious about post-transplant. And then there are other causes like financial difficulties. You are not able to work. You are on disability. So suddenly the income drops down drastically. Then the disability itself, that you are functionally not able to do what you were used to doing. In the house, outside, with friends, everything come to a halt initially after pre or post-transplant. Then family strain, the family goes through a lot of strain when someone is suffering in the family. And then personal stress of having to cope with the disease, the surgery, the post-surgery recovery. So those are some of the causes that cause anxiety in just other causes of anxiety. So there is a big role of the medications, and I think you get the education from the transplant team. When you come to see us, we also educate you about this, that the anti-rejection immunosuppressant medication does have an impact on your mood and anxiety. So medication-induced mood and anxiety disorders are very common post-transplant. They're linked to tacrolimus, cyclosporine, and corticosteroids. These are the medications that can cause some mood swings, fatigue, depression, anxiety. It's common mostly in the first few weeks to months after the transplant. So when the doses of medications are high, but as the doses go down, you feel better. So they may produce mood disturbance, especially when patients are at a higher daily dose. The steroids make you very jittery, agitated, you can't sleep, you feel you're on the edge. Sometimes the steroids make you feel irritable, you're crying a lot, you have manic-like symptoms because you can't sleep. Some people even have steroid-induced psychosis when they hallucinate, they see things or hear things. But we have to treat it. Dr. Weinrib is going to talk about it. We treat it and it goes away. So we can't stop the medication because it's important that you continue taking the medication, but we can adjust the dose and we have to treat it. So what is very important? Early recognition and treatment. It's very, very important, both by the patient and family members. Sometimes pre or post-transplant, family members notice symptoms before the patient himself understands what is happening. I have had that many, many times in my office. The family member will tell me, yes, I have seen these symptoms in him. Well, the patient really doesn't understand because he's so preoccupied in his mind with his own disease. Others recognize it before him. It's important to recognize and treat because it impacts your healing and recovery after transplant. So, why? Because if you're depressed or if you're anxious, it impacts your medication and treatment compliance. It results in, so you are not able to focus or concentrate. So there is a poor understanding of what is really happening, what you want, what you have to do, and follow up for treatment plan. This then results in graft failure, increased risk of delayed recovery and complications. So this is all like linked to each other. More anxiety, more depressed, you have poor understanding of what you have to do, what is expected of you to do. You fail to engage in care. Your care falls through. There is the serious complications of that. You get hospitalized. There is graft failure. So those are all hand in hand. So there is increased number of hospitalization in the first year following transplant if people have anxiety, depression, if that's not treated. And there is worsening of, and we have also seen that there is worsening of depression and anxiety from pre-transplant to post-transplant period. People would think, why would that happen? I have got a new organ now. Why would I feel depressed or anxious after my transplant? But the fact is, if you already have depression and anxiety which has not been treated pre-transplant, it happens a lot of time. People, when they tell us or they tell their social worker or tell their team that I am facing these symptoms, I'm having this, then they are immediately referred to us for evaluation. But sometimes people don't say, and so we can't understand. What happens is post-transplant, it gets worse. The reason is post-transplant, you're under more stress. Number one, you undergo a major surgery, which is a complex, prolonged surgery. Your post-transplant recovery in transplant patients is often complex. It's not very simple, like a simple appendix or a gallbladder operation. It's a complex surgery with complex recovery period. You are on those medications which have impact on your mood and anxiety. And then you have the recurrent hospital visits, seeing your doctors, getting the blood tests, all that takes a toll on you. So if you already have untreated anxiety, depression it gets worse post-transplant. And then that comes in your way of your recovery, as I mentioned earlier. So it's very important to identify, treat any pre-transplant depression and anxiety in order to enable you to have a faster and a better recovery post. So I will talk about some self-help remedies, which I think Deb has given you guys some handouts, which are some things which we can practice at home, and it's very effective. I have done it myself at times and before telling to my patients, and I have seen it's really effective. The first thing is, so what do you do when you feel anxious or depressed? I want you to imagine the stop sign which you see in the fore crossing of traffic. So if you have that vision in your mind, and whenever you go to that mode, you're feeling depressed or anxious, imagine that stop sign in your mind, that red stop sign. So you say to yourself, stop. First thing you say is stop. And the P here has been, double P has been put deliberately. I did a little research. Why did they put the P together? It's because they're emphasizing it, that stop. So don't go there, so stop. It's not an acronym. Then what do? You pause, take a breath. Don't react automatically. Then there are 5 questions that are very important you ask to yourself. What am I reacting to? What is it I think is going to happen here? Am I getting things out of proportion? Am I underestimating my ability to cope? Is there any other way of dealing with this? These 5 questions are important because when you are actually asking yourself these questions and finding out answer to these questions, when we are anxious, so this is if this is our normal state of mind, we are anxious or depressed, so our mind goes like this because it's anxious. So when we are asking these questions to ourselves and trying to figure out the answer, we are distracting our mind. And the anxiety comes down, not to the baseline, but maybe at least from here to here. So that is why it's important. It actually gives you an initial control of getting your anxiety a little bit down. So those are 5 questions, very, very helpful. The next thing I tell a lot of my patients in my clinic to do it is mindful breathing. This is not, and there is lot of videos on the internet and like YouTube, how to do mindful breathing. I just have a very simple thing which I have found out, and I have done it myself. It's very, very helpful. You sit comfortably, eyes closed and like a little straight. Bring your attention to your breathing. You imagine that you have a balloon in your tummy. Every time you breathe, the balloon inflates. Every time you breathe out, the balloon deflates. So you are breathing in, you're actually putting air in the balloon and your tummy goes out. You're breathing out, you're taking the air out of the balloon in your tummy and it goes in. So notice the sensation in your tummy, raising with the in-breath and falling with the out-breath. Your thoughts will come to your mind. That's okay. A lot of videos I have seen in YouTube, they said, imagine a leaf, imagine something going in the... It's difficult to imagine when you are so much anxious or depressed. So here it says, do not fight your thoughts. It will come. You are having a lot of thoughts. It's coming. You can't stop it because your mind is racing. You're anxious or you're very depressed. The negative thoughts are coming. That's okay. You just recognize your thoughts. Notice them, but then bring your attention back to your breathing again. So every time the thoughts come, don't get like, oh my God, why are the thoughts coming? That's okay. Let the thoughts come. But just concentrate on your belly again, that this is the balloon I have to inflate and deflate. Just bring it back. If you do it few times, you'll see your anxiety or even that mind getting negative, it really comes down. And it's very helpful. Use of 5 senses. This is something, is the mic working? This one? Down by the keyboard. Oh, okay. So we can, oh, do I have to on it? So we can use our 5 senses which bring our focus and attention to here and now. This is an extremely powerful tool to use even at home. When you are in the hospital, in the ICU, when you feel panicky, anxious, it's very, very helpful. So we activate our 5 senses, seeing, hearing, touch, smell, and taste. So how do we do it? We just say to ourselves, what are the things I can see? So here, if you just activate your sight of sense, you see the sense the site, you will just see the tables, you will see the screen, you'll see me, you will see people around you. Then what can I hear? We can hear Dr. Goswami speaking. We can hear some people flipping the pages. So what can you hear now? So you're just bringing it to here and now. Things I can feel and touch. What can I feel now? So if you just see the fabric of your chair or just your shirt, whatever is here, you just feel it. Things I can smell. Is it okay? It went off? Okay, that's what I was thinking. Things I can smell or I like to smell. You might not smell anything, but then imagine, what do you like to smell? What do you like the smell of? Is it lavender? Is it rose? What do you like? Things I can taste or like the taste of. So sometimes people can actually activate the taste sensation by rolling their tongue in their mouth to see what kind of taste they're feeling right now. Or if not that, what do I like the taste of? And then take one slow deep breath. So if you do this few times, and you don't have to be with any of the senses for long, it's like few seconds, 2 or 3 seconds. You first see, then you go to hear, then you go to touch, then you go to smell, and then you go to taste. So you just go within these 5 senses, and that helps to bring down your anxiety. This is not working.
Yeah, no, this one's.
And then there are some other remedies which I encourage people, mostly with depression or anxiety. It helps, very helpful. Engage in some kind of physical exercise, whatever is feasible for you at that time. Whether it's a walk, and you don't have to walk for like, hour or so, 15 minutes is fine. You can just gradually increase it. Swim if you like to swim, go to the gym if you like, cycle, whatever it's feasibly possible for you to do at that point of your recovery. Engage in a hobby or interest. Anything that makes you feel better. If you don't have one, find one. Take one step at a time. Don't plan too far ahead. So that helps in not feeling overwhelmed. Because if you're anxious, if you have too many things on your plate, you start feeling more anxiety and then you don't end up doing anything. So have small, realistic goals. Pamper yourself. Do something that you really enjoy and do something relaxing, things that make you feel better, whether it's going to your hair salon, whether it's doing your nails, whether it's going and watching any sports or meeting up your friend, whatever that makes you feel better. Positive self-talk. This is very, very important. I have given a handout of some of the positive self-talks, which I sometimes tell my patients to practice. It's very helpful. Encourage yourself. Tell yourself, I can do this. I am strong. Things are happening in my life and I have a purpose in life. So even if you don't believe it, you say to it every day and you feel better. So this is very, very important, positive self-talk. It helps to cope with a lot of your negative thoughts when you are depressed. So sometimes I tell, write it down and memorize it when you need it. So I have a handout for people about what are the very common positive self-talks you can actually practice. And then my last part of my talk is care for caregivers. Now, caregivers are a very vital source of care in transplant patients. I take it very, very seriously, and I think some of you know, in my clinic, I actually spend some time with the caregivers, asking them if they are doing okay, what is it their needs are, because it's so important that the caregivers who have gone through the transplant patient pre, during, and post, they are bound to be impacted. They undergo substantial physical and emotional stress. Studies have been done that suggest that caregivers of patients who are critically ill also experience high level of stress, anxiety, and depression. When you're taking care of others, both pre, post, and during transplant, it's important to love, honor, and value yourself. Taking care of yourself and your need is like performing regular maintenance on your car. It's very, very important. So caregivers, I want to emphasize, if you feel overwhelmed, if you feel it's impacting you, it's important you reach out to us and let us know. Tell your social workers that I am feeling overwhelmed. I feel I'm depressed also. I'm having anxiety. I'm just taking care. It's important that we hear you and we help you with your needs as well, because you are directly responsible for the patient. So if you're not taking good care of yourself, you will not be able to give that to your patient. It's very, very important that you take good care of yourself too. So what can caregivers do? Eat healthy, get enough sleep, get regular medical checkup, exercise, address symptoms of depression if you have, for moodiness, low appetite, difficulty or too much sleeping or low mood. Maintain or establish social contacts. Seek support from family or friends. They can help with household tasks. This is very, very important. Whenever I see any patient in my clinic, the first thing I ask is, who are your other support persons? That's very, very important. There cannot be only one caregiver. Yes, there can be one main caregiver, but there cannot be only one caregiver looking after a transplant patient. You should have a couple of other people to kind of help you, give you some respite so that you have some break, you have some time for your own, or else you're going to burn out for sure. Set priorities and realistic goals, like make a list, arrange your day, pace yourself, and set limits. People get so much involved and engrossed in taking care of the transplant, post-transplant patients, they forget taking care of themselves. And that is normal, because someone who's suffering, who has suffered so much, now has a new organ. We have to take care of the person, make sure everything is okay. So in the process, they stop caring about themselves and they have a high degree of burnout. So it's important to, while you're taking care of your loved one, to take care of yourself too. That's very, very important. I think I'm done with my talk. Thank you all. We'll take the questions at the end, and Dr. Weinberg.
Yeah. Okay, good morning. Can everybody hear me okay? All right, good. That's helpful. Just want to, before I start, thank some people. I want to thank Debbie and Sally for inviting us and organizing this wonderful morning and lunch, which I can't wait for. My stomach is reminding me every few minutes. Also want to thank the leadership of the hospital, who have really generously recognized the importance of our role here and allowed Arpita and I to work both full-time as psychiatrists for the Transplant Institute and not the rest of the department, which is pretty unusual. I'm not sure that this exists in any other program in the country. And thirdly, and most importantly, I want to thank my patients, because I think the majority of what I know, I learned from them. And it's really a collaborative experience, and I'm going to talk a little bit more about that. So let me get started. First of all, you see, for those of you who remember Peanuts in those days, you have a choice. You can either get some friendly advice and pay a little bit less, or you can go to see the psychiatrist, pay a little bit more, and maybe she'll snatch the football away from you and you'll fall down and maybe you'll learn something. I don't know. All right. So by overview, I'm going to talk about some of the myths about what it means to come and have to see the shrink. Our role as transplant psychiatrists, the process of the psychiatric interview, kind of draw back the curtain on that issue. Some of the myths that I've learned that people bring to the transplant process that I think are important for us to address, and a little bit about psychiatric treatments. I'm not going to get into great detail, but more about the process. And then finally, I'll put up some resources for you guys. So some of the common myths that float around about seeing the psychiatrist, which come from movies and books and things like that. First, I just want to distinguish what we do from psychologists, who are a very important and very closely related field, but not the same. So we are medical doctors. We once learned how to stitch people up and deliver babies, but we chose to do this instead because it's so much better. What we don't do is read minds. People often think that we can read minds, especially at parties. And sometimes I'll mess with them and say, yeah, I know why you asked me that. You didn't really do anything wrong if you're asked to come see us. That's really important. Sometimes people feel like they're being sent to the principal's office. We hope that that's not the case for you when you come to see us. And seeing a psychiatrist doesn't mean that you're crazy. It means that you might need some help with some of these issues. And if you do have a problem that is more serious, we'll take that seriously and help you with that too. Finally, we won't see you forever, so you're not locked in to see us every week for the rest of your life. If we do our job right, we'll create for you a period of independence and functioning so that you can do without us until you need us again. But you can come in and drop in when you need us and take off when you don't. So in terms of our role, and this is something that I have to explain a lot of times to other doctors and team members from other programs because they really don't know what we do. And I understand that. I think for many, many years, I tried to explain to my parents what I did, and I'm pretty sure they never got it. But we are members of the transplant team. So we go to the transplant selection committee meetings, and we contribute to that process. When we see people for an initial evaluation, what we do is we look at their strengths, and we look at their challenges, and we do that in order to guide a comprehensive plan to get people on the list and to keep them healthy. And in terms of the plan, we might make up a treatment recommendations, which may involve ongoing individual counseling and therapy, as well as medication management, or one or the other, or both. And it puts you in a position before transplant to prepare for this event, very much like an athlete who's in training. Training not for a little race, but for a marathon. And finally, we focus on continuing care. That's what we've been able to do more than anything in the last 2 years, and I've found very, very rewarding to me. So what is the evaluation? Well, when we first meet you, we're going to introduce ourselves, and we're going to explain our role to you. We're going to let you know that what we talk about is shared with the transplant team, and that the purpose of this initial meeting is to identify those areas that we think might need some help so that we can get you ready for listing and keep you healthy. We are not there to block your road to the transplant. Some people come in, they think that we're like the Roman emperors, like live, die. No, that's not what we do at all. We see it as a process, and we're working to help you get where you need to be. We need to get to know you. We want to find out about you. We want to know what your background was. We want to know, how things went for you when you were a kid, and how school went for you, and how things are with you and your family. And we do want to meet your family, or whoever is a loved one or someone that you identify as an important support person to you, because we feel that having more eyes on you helps us to help you. We're going to ask you questions about whether or not you've seen a psychiatrist before, whether or not you've had problems with addictions, whether or not you've had treatment. And then we're going to make sure that you have time for questions and provide for you a summary of what we think is going on and our recommendations. And what I always tell everybody is that there won't be any surprises here, no secrets. What I'm telling you in my office is exactly what I'm going to share with the transplant team, nothing less, nothing more. So over the years, I've come to recognize that there are some misunderstandings or myths that people bring to me when I first meet them. And I find it's really important to address those at some point. One of them is that, in pre-transplant, the reason I'm talking to you guys about this is because you will interact with people before transplant. They will look to you for guidance and advice, and you may be able to help them with some of this information. Often people think that we're the last one that they need to see to pass the test. So if I'm going to get listed, I got to pass the test with you. And that brings me back to, hang on, I'm not here to judge you. I'm not here to, tell you that you can or can't do this. I'm here to figure out a way to help you get there. One really intense and important one, and I think that this might even require an entire different talk, but I want to just mention it, is that people feel a lot of feelings about the donor and the donor's family, and that someone died in order for them to live. And one of the things that I stress to people is that those donors would have died without being organ donors. They would have died anyway. But either they and their family have made a decision to not let those organs go in vain, and that actually helps the families of the donors to cope better with this tragic loss that they go through. And so really, it is a terrible tragedy, but people on the family side, on the donor side, are grateful for the opportunity to help all of you. Some people say to me that there are so many others who deserve a transplant more than I do, and I'll probably never get one anyway. So they're probably thinking along the lines of a depressed person, a lot what Dr. Goswami was talking about in terms of having kind of negative self-concept and difficulty in seeing two sides of the issue. But also people sometimes feel like they got themselves here through their fault. Like maybe they smoked too much, or maybe they ate wrong, or they didn't exercise, or whatever it was. But the truth is that this is a far more complicated issue than that. And, you know, I'm not there to help you beat yourself up. You can do enough of that on your own, but I don't want you to, because it isn't healthy, it's not accurate. And I think it's important to know that there's no reason why you shouldn't get a second chance, no matter what was going on in your life before this. People say I'm depressed, I'm anxious. I've talked to my other doctors about this, and I can't take any of the medicines that you would want to give me because they're going to be harmful to my organs. And I'll talk more about that. It's generally not true. Or they're afraid if they are going to tell us that they have a history of depression or anxiety or addictions, either in the past or currently, that's going to interfere with their ability to get listed or be transplanted. And again, we are there to get enough information, as much information as possible about what is going on with you, that we can help address a plan to make this work better for you for the long run. So telling us more is not actually going to interfere with your getting on this list. So why do we treat? What treatments are there that are available? Some of this has been gone over a little bit with Dr. Goswami, so I'll fly through it. How long does it have to last? And what if I can't get the treatment? Or what if I don't want to do that? How do I deal with that? So why do we treat? We treat because it's good for you. Big surprise. The numbers that I saw in some of the papers I've reviewed are a little bit higher than the ones Dr. Goswami quoted, but suffice to say that more than half of post-transplant heart recipients will go through a period of depression and or anxiety at some point in their recovery or in their lives. And psychiatric treatment of these disorders has been documented to be very helpful in terms of maintaining pre- and post-transplant health. So helping people to remain adherent to all of the medications and all of the complex questions that they have about all of the things that are required of them, to get to their follow-up appointments, to manage all of the diet and the exercise issues, to avoid self-medicating with either food or with drugs or with alcohol, and find other ways of coping. And the other thing that I want to stress is that hope is one of the most important predictors of survival in transplant, and actually in about 20 other chronic diseases in medicine. And so when someone is hopeless, I see that a little bit like an emergency. I'm going to be very assertive with them about treating that hopelessness in the best way that I can, because I know that that's going to improve their chances in the long run. So how long does treatment have to last? Well, there's not necessarily a rule about that. I mean, as I said earlier, people can kind of come in and stay for a while, or they can drop out and come back. But really, it can take a while for an appropriate treatment course to go through. You know, I'll sometimes ask them, how long do you think I'm going to need to see you for you to do okay? And they might say, well, I think I'll be fine in 3 sessions. And I'll be like, well, let's add that up a little bit more. It might take actually 6 months before you're really, really stable. But the time that we invest up front is time that we get back on the back end of this thing. So what if I can't do this, or I don't want to do it? What if the doctors and other team members are saying, I have to see the psychiatrist, you need to get help with this stuff? but I can't do it. I can't get there transportation-wise. I can't afford it because there's a copay. I can't get there because I can't leave my children or my family. They need me home. And the answer to this question is, these are all issues that can and should be solved. There is no problem, I think, that we can't overcome to make sure that you get all the help that you need. We just need to know what those problems are, and together we can problem solve. For people who don't want to do it, my question to them is, why not? What gets in the way? Is it an issue of stigma, which I don't have here, but I can't remember. I may have taken that out. Is it an issue of stigma? Like, are you afraid to see the psychiatrist because of what other people might say? Well, that may be the case. But it's based on misinterpretations of our role, and I think underestimating how well you can do with help. And it's important not to be afraid. A good psychiatrist, a good therapist is not going to draw more out of you than you're ready to have drawn out of you. You may have a lot of things that are very painful and difficult to talk about. We understand that. We're not going to just get to that immediately. We're going to work together at a pace that is mutually acceptable, and most importantly, driven by how well you're doing and what you feel comfortable telling us. Whoops, I went past this. What treatments are available? Well, there's talking therapies and there are medications and there are combinations of these things. So talking therapies can be one-on-one, individual therapy. There can be group experiences. There can be complementary and alternative therapies. People are talking about using various herbs and other remedies, but also acupuncture and things that can be very helpful. It's not just Western medicine that wins the day. Pastoral counseling, very important. A lot of people really rely on their faith, and there are therapists who are trained in this area specifically to work with people of all faiths. Medications. There's a couple different classes of medicines that we work with. Antidepressants, medicines for anxiety, anti-anxiety medicines, medicines that treat delirium or cognitive problems, help with sleep, and pain management. Those are some of the main areas that we are trained to deal with in our work with you. And I'm not going to get into the details of what are the names of all the medicines. It's a great song. I love that song. Some of the non-medication or individual therapies, and there are so many more than are on this list, but some of them you may have heard of. One is called cognitive behavioral therapy, or CBT. And we're big on that here because we invented it here. So the Beck family, Aaron Beck in particular, was the first person to develop or have an interest in cognitive behavioral therapy because well over 50 years ago, he recognized that our thoughts really influence our behaviors and vice versa. So it's a little bit like, is the glass half empty or is the glass half full, or I always break the glass. But whatever it is you're thinking, that can affect how you do things and how you approach things. And we can work with you to help you to relearn those automatic thoughts, which may be very negative and may be destructive to you. Motivational interviewing is a very interesting type of therapy. And by the way, these are all evidence-based. They've all been shown to be effective in scientific studies with people. Not easy to study this kind of stuff, but when they do it right, it's very important for us to know so that we know how to help people and match them with the right therapy. Motivational interviewing was initially developed as a way to treat people to quit smoking. And what they came up with was that people are at very different levels of understanding of their problem and might need different approaches based on that. So for example, there's something called the pre-contemplative phase. I'll give you an example of that. Have you ever thought about quitting smoking? Actually, no, it's never occurred to me. I don't think it's a problem. Or the contemplative phase. Do you think that you should quit smoking? Yeah, I've thought about it, but I really haven't done much more. I don't really have a plan. I don't really know what I'm going to do. Then there's the action phase, which is, yes, I do know that I have a problem, and I've contacted the American Cancer Society, and I'm going to get a prescription for Chantix. So they're already, halfway there. And then the maintenance phase, which is where you've already treated the problem and you're doing well, and you want to maintain your success. And what we help people do with motivational interviewing is kind of move across that spectrum of decision making so that they're in a better place to get where they need to be. And we do it in a way that's very collaborative. There isn't like, you don't say to somebody, you're this or you're that. It's more like, what do you think? Or how do you feel about this? Or what are the pros or the cons of what you're doing? And then you actually make the decisions about your own behavioral change, and that gives you the right to own your success. And that is what lasts the longest, I think. There's art therapy, there's hypnotherapy, and these are not fluffy therapies. These are things that take hundreds of hours of treatment or hundreds of hours of training to actually do right. Supportive therapy, psychodynamic principles, family therapy, drug and alcohol rehabilitation. Don't have time to get into all of those things, but these are examples of the type of diverse experiences that you can have coming to us. Now, we're not trained to do all of these things either. In the same way that your surgeon may not be trained to take care of your diabetes the same way as the endocrinologist can. But we do know people who can do this, so we can make referrals. We can get you plugged in. Commonly used classes of medicines, already described these a little bit, so I'll skip right over it. But what can we expect from the antidepressants, let's say? Well, first of all, what I tell my patients is that this is not an exact science, this psychiatry business. So the first medication that we try to help you with may not be the right one. But if you're willing to work together with us, we'll get there. And it takes time. So people say, well, how long before an antidepressant works? And the answer to that is variable. I've had people tell me that they felt good in 3 doses of an antidepressant, and I have no reason to not believe that. Or it's taken people 10 days, 2 weeks, up to 3 months to get a full effect of the medications. Now, these medications are not panaceas. They're not going to fix everything. They work much better with therapy and counseling, but they also don't always work as much as we'd like them to. They don't always do enough. We can help with that too. There are other strategies to augment or support or increase the benefit of these medications, and it takes teamwork. So what I always tell my patients is, I don't want you to have more side effects than effects. I want you to have a good experience with this, and if you're feeling lousy on the medication, call me, talk to me. This is why I get the big bucks. I'm here for you. I'm in this field because it matters to me, and I know that if we can work closely together at the early stages of working with a medication, it's going to help you in the long run. So sucking it up and putting up with symptoms is really not okay. I don't want you to do that. I'd much rather you tell me about the problems, and let's see if we can't problem solve this together. Common mistakes of treating with antidepressants is that the dose is too low. It turns out that 90% of antidepressant treatments are managed by primary care physicians. So only 10% of you are lucky enough to get to sit down with guys like us. And a lot of those primary care physicians are excellent at what they do, but some of them are just too darn busy, and you may slip through the cracks. And so you may not have had an opportunity to get the dose increased to a level that's actually going to make a difference, or the duration of treatment is too short. It may be that you stopped the medicine too quickly, or that it was switched before you had a chance to see the benefit of it. Probably the biggest mistake people make, which is like the antibiotic mistake, which is I stopped it because I felt better, because it was time to do that, and I don't want to keep taking these forever. But the truth of the matter is that depression is a very complicated and deep disorder that affects your neurotransmitter function in the brain in pretty significant and long-lasting ways. It takes a long time to get really depressed. It takes a long time to get undepressed. So it can take as long as 9 months to a year on an antidepressant medication for a depression to fully remit. Believe me, you'll feel better much sooner than that. Like I said earlier, it could be 10 days, it could be 3 months. But the point of it is you've got to stick it out with us and make sure that when you are feeling better, you don't stop the medicines on your own, because your depression is likely to flip right back. It's likely to relapse. One thing we've learned is that if you've had a couple of episodes of depression in your life, and these are the big depression. This is the serious disease type depression, where it's lasted for more than a couple of weeks, feeling hopeless, unable to get things done. If you've had a couple of those, we now recommend that people stay on antidepressant medications for the entirety of their life, in the same way that you would if you were on blood pressure medications or medicines for diabetes, because we know that the relapse rates are over 90%, so why go through that? And we don't think that there are any severe long-term consequences of staying on these medications for that period of time. Either way, we watch it very, very closely. Some people, a lot of people actually, tell me that they take their antidepressant as needed. When they're having a good couple of days, they take it. When they're not having a good, or they don't take it when they're having a not good couple of days, they take it then. They work best if you have a steady state blood level, which means taking it every day, just like you do your immunosuppressants. They're really important. That's the best way to get the best out of them and to make sure that they can actually work. What can we expect from these medicines? Antidepressants don't just treat depression. They're also the gold standard treatment for anxiety. They can help your mood become brighter. They help with irritability. They help people increase and improve their energy. These medications are not addictive, but they do make long-lasting changes in the brain that if you stop the medicines cold, you will feel withdrawal. We call that a discontinuation syndrome, but make no mistake, it's withdrawal. That doesn't mean it's addictive. But what it will feel like is flu-like symptoms, agitation, irritability, anxiety. There's been a lot written about this. And what we think is that in order to taper a medication, an antidepressant appropriately, we can't do it in a couple of weeks. It can take months to do it right so that you can get through this period of time comfortably. So again, not addictive, but you really want to stop it with observation, with collaboration, and very slowly. It is not a happy pill. You don't just flip a switch and you're feeling great. It's a slow process, but a very, very rewarding process. And one of my mentors said to me, it's like you're driving a boat. And by the way, is there any other thing about, how do you move a boat? Are you driving a boat? Are you piloting a boat? Floating a boat? I don't know. But you're driving the boat. And you're pulling a bunch of anchors behind you. What these medications do is they help cut away a lot of those anchors so that you can pilot that boat with a lot more efficiency, with more speed, and hopefully you're feeling better about doing that and using less fuel. The anxiety medications. Often, before we prescribe, we ask you about why you're feeling this way. Because sometimes you don't need medicines. Other times we can make adjustments together in your life that'll make the medicines more effective. As I said earlier, antidepressants are often what are used. And sometimes we use benzodiazepines like Ativan or Klonopin, clonazepam, which act as a bridge during that time to help you to reduce your anxiety until the antidepressants have reached their full effect. And then we're going to try and take those benzodiazepines away. Some people need to take them for the rest of their life. We understand that. But ideally, if you don't need to take them for long, long periods of time, we want to help you get off them as soon as it's reasonable to do that, because some people, not everyone, develop tolerance to these benzodiazepines, meaning that over time they might need more to get the same effect. And because, again, when you do stop them, there is some withdrawal. So again, this is another argument for why we have to work as a team. Sleeping medications. Why is it you can't sleep? It turns out that the most prevalent reason, the most common reason that people can't sleep, and this affects the majority actually of people in the country, is not exactly a primary sleep disorder. It's called something called conditioned insomnia. And what that means is that you've trained yourself not to sleep. So what happens is, an hour or two before you go to bed, you're thinking, it's going to be one of those nights, I'm not going to be able to sleep, and you start getting worked up already. And then you lay in your bed, and you lay there for hours not sleeping. So what you've done is you've trained yourself to associate the bed with not sleeping. What we have to do in that case is untrain you so that you begin to see the bed as the place you sleep, and then the anxiety goes down, you have greater success of being there. And the simplest way to do that is just don't lay there in the bed when you're not sleeping. If you're laying there for a couple of minutes and it's not working, get out of bed, go somewhere else, do something calming or relaxing, which, by the way, means do not look at screens. Studies are really clear about this. The blue light that you get from telephones, tablets, cell phones, tablets, and computers is stimulating your brain. It makes it much harder to go to sleep. It's why we tell kids with ADD, get that thing out of your room for a couple of hours before you go to bed, or you really, really will have trouble sleeping. So we don't always need medications, but we need to have a conversation. If you need sleeping pills, there are some that can be used long-term, and there are some that can be used short-term and should only be used short-term. And we could talk about that depending on the specific situation. What about side effects of the transplant medicines? How do we deal with that? That's a big part of our job on a day-to-day basis. Immunosuppressants are associated with fatigue in 75% of people who take them. People get headaches with higher doses. People, as you know this better than anybody, tremors. Sometimes people can get confused or even forgetful on these medications. And as Dr. Goswami said, sometimes early on, people can lose touch with reality and become psychotic on these medicines or even paranoid. All of these things work through the neurotransmitter system of the brain and how these medicines affect that. And what we try to do is reverse it or lessen the severity of that problem. Steroids are also infamous for causing problems. They cause mood changes. So people tell me when they first get on high doses of steroids after transplant, they're crying about everything. They're watching a commercial and there's a puppy on the TV and they're bawling. And it's like, why? I never cried at puppies before. What's going on? And the answer is that your emotions are heightened. That means if you're getting upset, you're going to get more upset. If you're getting sad, you're going to get more sad. And if you're going to get happy, you're probably going to be a little too happy. You'll be almost elated. But know that that's temporary, and it's related to the dose of those steroids, which do come down over time. People can get very anxious on steroids. They do increase that tremor in the beginning. I don't expect anybody to sleep who's getting high doses of steroids, but that's something that we also know how to help you with. And people overeat on them too. All of these things need to be managed, and sometimes those steroid doses go back up again years and years after you've been transplanted based on all kinds of medical complexities. We're there to help you with those things so that you can sleep, so that you can relax, you can have conversations, and you can stop crying at every little thing. There are drug interactions between transplant and psychiatric medications. However, they're not as bad as most people think they are. Some of the medicines that we use can increase or decrease the blood levels of immunosuppressants. And we're really on top of that. The last thing in the world we want is to get you guys into a rejection episode because of some medicine we're using. But almost all of the psychiatric medicines that we do use are safe and will not cause problems. It's very rare that we get one that will do that we have to use. We have other alternatives, and we always use those other alternatives. But just to be on the safe side, in case you're somebody whose body is a little different than the next guy, we are going to test for those interactions using very sophisticated computer programs before we give you any medication. We'll consult with the other transplant doctors to make sure that they're in agreement with our decision. And we talk with transplant pharmacists who are some of the most amazing people I've ever met. I can't believe how much they know. They're like walking encyclopedias. So together we make decisions in your best interest, and hopefully those decisions are not harmful to you. What we are trained to do is to start low and go slow. So when we begin a medication with you, we might start at a half or a quarter of the starting dose because we don't know how that's going to affect you. And giving you a big time side effect at the start generally doesn't do much for adherence later. People just don't want to take it, and I don't blame them. I don't think I would either. I wouldn't want to have to figure out how to get through that. So we start low, we go slow. Taken together, studies are very clear about this. Actually, it's really interesting. If you do brain imaging and you look at what's called functional imaging, where different parts of the brain light up when that part of the brain is being activated, what you'll see is that there's a different part of the brain that responds to talking therapies than it does to medications. And if you put the two together, that response is even better. It's even greater when you look at the functional imaging of the way the brain works and compare it to somebody else. And if you, over time, compare a brain that's been treated for depression effectively to somebody's who was never depressed, you won't be able to tell the difference. But when they are depressed, you will be able to tell the difference. And you can see that on neuroimaging. That's something that's more of a research tool. It's not something that we use day to day in practice, but it's important to illustrate that these problems, aren't an issue of your will or your weakness. It's a brain problem. And we want to help you with that, with the tools that we've been privileged enough to be trained to use. So the take-home points from today, I'm going to take the liberty of putting both talks together for these take-home points, and then it is close to noon, but we'll have time for some questions and answers, hopefully, and we're going to stick around too, so you can ask us that way. The role of a transplant psychiatrist is to help a patient get listed, and then to work together with that patient for the rest of the transplant team to maximize your care. Depression and anxiety are commonly experienced in the heart transplant population, actually in all of the transplant population. And those symptoms should be recognized early, and interventions early allow for the best results. We've learned some strategies that patients can use to help themselves, and we stressed some of the benefits of using those therapies in addition to talking therapy and medications to get you guys the best results. And I think that might just be the last slide. Oh, not quite. Resources. I guess we can get this handed out to you guys. There's a crisis hotline that you can actually text to. So if you're not home, you can do that. And they will get in touch with you. There's a suicide lifeline that's nationwide, as well as locals. Penn Behavioral Health is our psychiatric care program that's located at 3535 Market. And the number is here, Penn Behavioral Health. It doesn't take every insurance that we have, so you may find that that's the case, but then they'll make appropriate referrals. The majority of you will end up coming to see us anyway, and you don't have to worry about it. There are excellent things to read and rely on from the National Institute of Mental Illness, NAMI, and from the National Institutes of Mental Health through the National Institutes of Health, NIMH. So you can look at those websites and get a lot of good information. So I think we're done. So thank you.
Thank you, Bob.
Sure.
Stay right there if you would.
Stay right here.
We are past our noontime lunch thing, but let's take one or two or three questions real quick. And as I said, both of them will be here, so you can take one-on-one questions with them there. Anybody have a quick question? Yes. Nice and loud.
Effort being made with psychiatric medications to check their effect on long-term use and dementia.
So I'm sorry, your question was what medications, or are there medications that have been used?
Has there been enough research
Oh,
to rule that out or
rule it in. So has there been enough research to tell us what the benefits are of using medications for people with dementia? Yes and no. There's been a lot of research. It's a super active area of what we're dealing with and what psychiatry and drug companies are looking at. The problem is that we haven't made great strides yet. The medications that do exist have some benefits, but we're nowhere near where we need to be. There was recently some articles that were written that showed some great promise in animal data, but not in people yet. But they're hopefully going to be getting there. It is a huge push by the National Institutes of Health, and a very good question. Mm-hmm.
Another question. Anybody? Go ahead.
Great question. Yeah. Well, there is an answer to that question. You may not like it, but here it is. Preclinical or animal researchers have used rats as a model of depression for a long time. And they do something called the forced swim test, which is just what it sounds like, where the poor little animal is dropped in a pool of water. And if they give up swimming quickly, they're depressed. And if they keep swimming, they're not depressed. But we don't let them die. They come back out. They also do brain imaging, and they can look now at a lot more than we could in the past. But that's one answer. Yeah.
One more question, yes, Bev.
When did this all start with psychiatrists and therapies? 5 years ago, 10 years ago?
Very good question. So do you want to,
transplant?
for transplant or for,
Transplant.
oh, yeah. Yeah, so, all right. So the question is, how long has this been going on? How long have we been helping people with transplant? Or maybe another way to look at it is, how long has transplant psychiatry been a thing? And the answer is, actually here. I've been here for almost 25 years. That's when it started. And I managed the psychiatric needs of the Transplant Institute on 50% time for most of those years. I could not actually do ongoing treatment because of that. I mostly got people that I met and did some individual assessments and then made referrals to the community. The problem is that the community didn't really know what to do with you guys. They were either afraid to give you medicines or they were not sure what you were going through. So I was able to convince, as I said earlier, the leadership of the hospital of the importance of really, really training and studying in this area specifically. And I have to say, it's been a great privilege that the doctors that I've worked with have just opened their doors to me when I started out all those years ago, and this wasn't really a field. But together, we were able to make it into something, and I'm not the only one who does this. There are probably a couple dozen of us around the country now that do this. But I couldn't have done it without the help of my colleagues, who were very, very willing and to guide me with what they knew. And I learned mostly, like I said, from you guys. Yeah.
One more.
Yeah, Tom.
Doctor, I'd just like to say thank you. When I came to see you, I was very depressed. I was about a year out of transplant, and some of the side effects of medications that I was taking were really wreaking havoc on me, and it's been a very good experience being under your care. I just want to say thanks.
Well, thank you. I'm very glad to see you doing better. Nothing makes me happier.
All right, again, when we have lunch, you will have time with them. There are two types of people in our audience today, right? Those that just saw all that and said, oh my God, I've got all of those things. Then you got the other type that said, boy, am I blessed, I don't have any of those things. And I suggest that the right reaction is either one of you, isn't it great that we have these resources if and when you have these issues to turn to? And our team is aware of them and will refer you to them. So don't hesitate. I've had emails from people. I say, you need to talk to Deb Gordon or Sally. They will have access to these kind of resources. And so I would say, pick up the phone and call them. It's the best way to do that. Also, in follow-on to something that was talked about here, Trio Chapter of Philadelphia on the 21st, we'll have our next speakers meeting, and Lara Moretti, who's talked here several times from the counseling sessions, the compassion group over at Gift of Life Donor Program, will be our speaker. She's going to be talking about survivor guilt, which is one of the issues that he raised here. So first of all, you are welcome to those meetings. They're held at 6:30 at night over at the Gift of Life Donor Program over on the other side of town. If you can't come to that, like we record these and put them up on YouTube, we do the same with those. And so if I have your email address, if you received the announcement of today's event through email, that means I have your email address. If you did not, if you got one of those phone calls from the girl, okay, if you got one of those calls, then we don't have your email address. And outside, you can sign up for that. And we're going to have a drawing from everybody that we've got an email address on for a special gift in just a second. But what I would like to do in closing there is say thank you to our, let me just back up real quick in here. Say thank you to both our speakers with a little token gift that help you with your own mental health. How's that? Thank you, everybody. Real quick, a couple other things. We want to say thank you, especially to our social workers, and also the Solid Heart of Gold Fund, which pays for the lunch you're about to have, and our social worker team 5 of them out there. You know some of them, you probably don't know all of them, but they are the ones that really drive the attendance. We had 69 people said they were going to be able to come out. We had a bunch of other people say, I can't make it today. They're going to watch the videos. You will get an email, if I have your email address, giving you the link to this video and to those other videos, so you know that, okay? There's other staff with us today. Please, if you didn't get an email reminder of this meeting, add your email address outside with Sally, and then we'll do that drawing later. And this is going to be the gift for those who have email addresses. We're going to do a drawing while you're at lunch and give you this very beautiful book, autographed by the author, by the way. All right? And one last thing is, one of the things that Trio Philadelphia has done, as I mentioned in the past, is produced and published a book for children who are in a family where somebody's getting a transplant. So it's to help them understand what transplantation is about. These are free. I always bring a couple. If you'd like one of these for your grandchild or some other young person, typical age, I would say, is probably from 6 to maybe 10 would benefit from this. You're welcome to come up and get one, okay? And so with that, we won't talk about the cancer program that we're doing with Trio. It's on our Trio website. I won't talk about that transplant presentation library where this video will be. It's on our website, and so much more. And so with that, we'll see you at the next one, whenever it is, and with whatever the topic is. Thank you for coming out. Lunch is now served.